Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
1 in 4 people die of heart disease here in the United States, and there are many tests today that may be able to show signs of heart disease, and treatments are better than ever. During this next hour, we have experts answering your questions about advancements in heart care right here in the border region in El Paso, Juarez, and Las Cruces. And as you know, this is a live program, so call us with some of your questions. The telephone number to call us at is 880-1313. Also, if you are young, unlike most of us, well, you're young, and you want to ask questions via Facebook and or Instagram, you can go to the Our Story portion of PBS El Paso and you can ask your questions there as well. This evening's program is underwritten by the Hospitals of Providence, and we also want to thank the Texas Tech Paulo Foster School of Medicine for manning our phones for the questions this evening. And this is the 25th year that the El Paso County Medical Society has been putting on this show, so happy anniversary. I'm Catherine Berg, and you're watching The El Paso Physician. It's interesting because I'll have some of these doctors on the show, and yeah, they're doctors, but I've known them for 20 years. We've been doing the show for 20 years. You know, he talks about farts, and he talks about diarrhea, and he talks about all kinds of things that nobody wants to talk about. And that's what's great about the show, because you get to hear those things on the show and go, I'm not the only one. It's great. It's the El Paso Physician. Big advancements in heart care. That's what we're here to talk about this evening. We have a couple of veterans with us this evening and a newbie. Directly to my right, we have Rob Anderson. He is the CEO of the Hospitals of Providence. He is at the Sierra campus. And then we have Dr. Shalom, and let me turn my page because that's how I did the way to Mulu Katla. And so you are the newbie on the show, and you've been a lot of fun so far, so we're going to have a great show tonight. And then we have Dr. Edward Ossie, who, again, these two are both cardiologists, and the show is all about advancements in heart care. And when we go through the questions this evening, we're going to have questions from the audience. We got a couple of questions we're going to talk about here, but the first thing I want to do, and Rob, we're going to start with you because you are on my right. That's just the way it happens. I've also been told by both of the doctors that Rob is cheating. And if you can see Rob, you will see what we're talking about. He's the one that has his notes. He wanted to write it on his hands, but no, he took his notes and he took his computer and he's here cheating. So we need to know that. Rob, what do you do?
But for the record.
But for the record. But for the record.
I'm not a physician, but I do play one on TV.
There you go.
So
I've heard that
credit
line.
to these
That's
gentlemen
Marcus
too.
Welby, MD, right?
I can be there as well too. Yes.
I love
yes.
it. So as the CEO of the Hospitals of Providence, Sierra campus, what is it that truly, what do you do all day, every day? And I know it encompasses a lot, but keeping it down to where audience members can understand it, what is it that you do?
Yeah, you know, I think that, you know, the benefit of being a CEO of a hospital is you get to see everything. And the benefit about being the Hospitals of Providence CEO at Sierra campus is the benefit to see the cardiac, the neuro side of what we do. So my daily job is to make sure all the operations are running smoothly. Make sure patients are taken care of through my staff, through our physicians, and really ensure that the type of care, the quality of care that we provide runs smooth. That's essentially it.
Yeah.
I do answer emails.
Right.
I do phone calls.
Right.
I do make notes for myself.
You do some research.
But I think
like that.
most people like to do that to make sure they're prepared.
Right. Bingo. Plan, plan, plan. I dig it. Dr. Mulu Katla, so you are the first time on the show.
Yes,
and Dr. Ossie said, how long is this? It's a half an hour, right? I'm like, oh, it's a whole hour. But it does go by super fast. But as a cardiologist, I know that people know you're a heart doctor. But if you could describe what you do, and I know you do some things with pediatric. I know that's not your main specialty, but in general, what do you do all day, every day? So that when people from the audience listen to you speak, it's like, I want to ask a question from Dr. Mulu Katla, or I want to ask a question from Dr. Ossie. What might that be?
Yeah. In a basic sense, what we both do is take care of patients. That's what we like doing, enjoy doing, and most of my day is spent talking to people. And then there's certain days that we do procedures, and I do procedures on kids and adults, and we do certain procedures that now have these advances that we're going to talk about today, where you can do it without opening someone's heart open. So there's a lot of things that we do, but at the end of the day, We just want to take care of people and make sure that they do well, and most importantly, try to bring advances to the field here in the borderland.
Nicely said. And I want to not apologize, but go back and say that both of you are interventional cardiologists. And so, Dr. Ossie, if I can have you expand on what Dr. Mulukatla was talking about when you were talking about prevention and or putting things in place to where something big doesn't happen. That's a big part of what you all do, which is fantastic. Dr. Ossie, can you kind of take that same question and explain to the audience what you do?
Yeah, I mean, my day starts off very early, and I typically am at the hospital pretty early, seeing our sick people that are in the hospital with heart attacks. And then from there, I spend most of my day in the office seeing patients that have not had a heart attack and have not had a stroke. And those are the patients that we really try and focus on to prevent them from having to come in to the hospital. So when we talk about primary prevention, secondary prevention, those are basically terms that we use to say, I don't want you to ever have to really need me in the hospital. I don't want you to have to come in with a heart attack. So that is primary prevention. So I am going to do everything I can. I'm going to check your cholesterol levels. We're going to examine you. We're going to see how fit you are. And there's a multitude of tests that we have available to us to kind of assess patients and assess their risk of having a heart attack or a stroke. So in addition to spending the day at the office dealing with those patients and those issues, where both of us, again, do procedures because that is what we do. We're both interventionally trained to take care of patients when you do need us, coming in from, coming in through the emergency room with the heart attack, that we're there to help you.
Exactly. And I like the way that you say that too, because sometimes that is the first sign that you have a problem. Oftentimes, I think, through the years, that's something that we've talked about. The first time you realize you have a heart problem is when you need to go to the hospital. But people now, with the idea of seeing their doctors more regularly, I think that's become more and more common over the last couple of decades. You can see if someone is more apt to have issues. Rob, I'm going to ask you first, and if I throw a question your way that needs to go to the other two, you just let me know. But we're talking about advancements, and so as CEO, you're looking at different things that the hospital is bringing in cardiology care. What is it about cardiology care, and again, it's like every 3 years is something new, every 3 years, more money needs to be raised because we got to get this machine in, or we got to get this procedure in. What are some of the new things that are going on at your place?
Yeah, and that's a great question. I think really, when you look at cardiology and any service line, there's always going to be advancements, right? It's advancements in medicine, advancement in technologies, and it's really driven by the patients and the patient needs. And the borderland El Paso market is a little bit different than other areas. And so as we look at new technologies, it says, what don't we have here that you can maybe get in a larger, bigger community? And so that's how we take an assessment of what do we need to allow those, to allow our community to stay here to receive that higher level of care. And the cardiac services is one of those, right? We brought in the structural heart program almost 3.5 years ago, which has been successful. That it's the only one in the region and only one in 350 miles from El Paso that has that. So before, one, we didn't offer that, and two, they have to go to a Dallas, a Phoenix, or a San Antonio to get care. And so as we look at that, we assess what the community is, what the need is, and really where the technology advancements are going in order for us and our physicians and our staff to really provide better quality care here at home.
Okay. And that's nicely said. I know that before the program started, Dr. Ossie and I were talking a little bit about accreditation. And I know that you were involved in that process. And Dr. Mulukatla, I'm not skipping you. It's just that right now we talked a little bit about that. But I'd like to talk about accreditation because I know with different organizations, different ways of being in this world, you want to go to someone, whether it's a doctor, whether it's a financial advisor, et cetera, that's accredited. What does that mean, and what process did you guys have to go through to get that?
Yeah, that's exactly right. I mean, when you look at physicians, there are physicians that go through a process to become board certified. They've gone through multiple testing to get to where they need to be. And now we have an institution in El Paso that has reached for a higher level of care. And the American College of Cardiology has an accreditation process that looks at facilities and makes you go through a very painful process of dotting the I's and crossing the T's to make sure that your patients that are being treated there are getting the best care possible. There are a multitude of steps that you have to take, multiple issues that patients, that the physicians have to take over during the process to make sure that we are giving the best care possible. And all those are standards. So everybody that comes in with a heart attack has to go home on a cholesterol medication. They have to go home on aspirin. And we have certain metrics that everyone has to meet. And if we don't meet those metrics, then you don't get certified. And we are certified in as our chest pain center, and we are certified in heart failure. And we are the only place in El Paso that has done that. And there's a lot of people that are involved in the process. It is not just a one-man show, and everyone has to take responsibility for it. But what it really means is quality.
Bingo.
That's what it means when you're accredited, is that you are meeting quality measures to take care of those patients in the standard of care fashion that the Mayo Clinic would do, that the Cleveland Clinic would do, and that's what the hospitals of Providence have achieved.
Okay.
Yeah,
And yes, Rob?
Yeah, one of those I want to piggyback on what Dr. Ossie says is, so this is our 4th year in a row to be Heart Care Center designated.
Okay.
So there's only 42 hospitals in the country that have that designation, and only 5 in Texas, and one of those is here in El Paso. And what that means is that, going to the American College of Cardiology, we essentially have their stamp of approval that says we provide the best patient care.
Bingo. It's like the good housekeeping seal.
Yeah,
That's
it's
the way I
exactly
look
right.
at it back
It's
in the old
exactly
days.
right. We've got standards we have to meet. We've got certain metrics we have to meet, and we meet those, and we do it every year. So we have to get reviewed on this every year. So it's something that I'm personally proud of, because the team and the physicians do all the work in this too. And so it's great to have that here, and even more exciting to have that here as part of El Paso.
Agreed. And I know that in years past too, and it's becoming less and less so, we are not sending patients away from El Paso like we did. Again, we talked about this being the 25th anniversary of this program. When I started this program, we did a lot of, when do you send a patient to Dallas? When do you send a patient to Houston? Those aren't questions that we really deal with so much anymore, which is fantastic. So I thank you all, every single doctor that's involved in this, and organizations, everything that goes into this. Dr. Mulukatla, I'd like to kind of switch and go into cardiology care. And I know that Dr. Ossie, thank you for bringing the toys.
Of course.
I don't know if the camera can pan over there, but I would love for you, Dr. Mulukatla, if you don't mind, to take whichever one of those toys that you see, that you can explain what the heart does. I know we all think we know, but we don't know what we don't know. So there's chambers, there's blue blood, there's red blood, how does all that work? And I do this kind of as a starting point where people start having questions about valve issues. People start having questions about cholesterol, and then, HDL versus LDL, and high blood pressure and low blood pressure. So I'd like to kind of get a sample of this first, and then we're going to start going into all these questions that everybody is going to start asking us.
Absolutely. So I think I was laughing with Dr. Ossie because we have the same model in our office. I think they may only send
Can you bring one so we can just keep one in the studio? If there's one sitting in a closet somewhere, we need one here all the time.
Well, I'll try to, obviously this is a very complex,
Of
how
course.
God designed this. It's amazing in and of itself.
Right.
But the heart, the guys at this table probably believe is the most important organ in the body. But the brain's pretty important too. But in this case, what is important is that the heart's function is to, and I don't know if you can see this, but there's basically 4 rooms in the heart, and there's 4 doors. So each room has a function, and the right side of the heart has 2 rooms, which you can see here, and the left side, if you can see, has 2 rooms, and it's on this side of the heart. And the basic idea is blood comes back from your legs and comes from your head, from the body, and goes to the right side of the heart, and then is pumped to the lungs, where you take a big deep breath and you get oxygen, and that feeds this blood that needs oxygen, and it comes back to the left side of the heart, and then goes through a couple more doors, which is the mitral valve, and then the left ventricle, which is like your V6 engine pumping it through the body.
Check you out. Yeah.
And then out of that, it's the last stop on the train station, which we'll talk about later, is the aortic valve, and then it goes to the rest of the body.
Okay.
Now, what's interesting is the way the heart gets its blood is actually when the blood goes out, it comes back, and it goes to these, I call it like the gas or like the pipes, but they fill this engine, which is the V6, and that's the blood vessels where you can have a heart attack if it gets a blockage.
Right.
But this is what's the fuel that allows this engine to work.
Gotcha.
And basically that's a simple way of doing it. I'm sure there's a more elegant way of doing
No, this is
it.
exactly what we need. This is exactly what we need. When you get to explain it to where people completely understand what's happening here. So when we're looking at blood flowing in, blood flowing out, and the audience knows this because I've been doing this 25 years. So I have a mitral valve that sometimes behaves, sometimes it doesn't. You know, so sometimes there may be clean blood in there sometimes may not. But there are chambers that, for the lack of a better word, are more important than other chambers. So let's talk about those really quick before we move on. Because the mitral valve apparently is a valve that's, it's fine. But if there's another valve that has an issue, we got more problems. Is that correct? With the valves, the different valves in the different chambers of the heart?
Yeah, I would say that all of them have to function appropriately for what they need to do. We probably think the aortic valve is probably the most important, then the mitral, the tricuspid, and the pulmonary. But if any one of them gets infected or has a problem, it could throw the whole operation off.
Right.
Because they're all working together to get the blood out. So they all are important, and sometimes we may fix other ones than some of the others, but in general, they sort of work in unison, and so they're working together to get the blood to where it has to go. And if you have a blockage of your valve, or you have a blockage in your heart artery, or if one of the valves leaks, as in your case you're talking about a mitral valve, that can also hinder the ability for the blood to go where it has to because it's going backwards or it's not getting out. There's a lot of little things, but the idea is basically a tube, and it's trying to get where it needs to go, and if you have some hindrance, that can cause a problem for you.
Right. It's all about the valves. I get it. Dr. Ossie, what I'd like to do with you is kind of take that question, and so many of us in this world feel some kind of AFib, right? And I feel like the media has just gone crazy the last 5 years with medications on this, medications on that. If you have AFib that's not associated with a heart valve problem, what is AFib? Because in these commercials, you don't understand what that is. It's like, well, if it doesn't apply to you, you don't know. So talk about missed heartbeats, fast heartbeats, et cetera, just in general what AFib is and anything that's associated with that. And the electricity that's involved in our bodies to make some things happen when it comes to valves.
Okay.
Small question. Very, very small question.
Loaded,
I know.
Atrial fibrillation is probably the most common arrhythmia that hits the older population. So, I mean, really, as we get above the age of 60, atrial fibrillation is extremely common. And that's why, and the therapy has changed for it. And that's why you see all the commercials on TV now about Xarelto and Eliquis. I mean, and they're great drugs, and we are using them quite a bit because they've taken over the use of Coumadin in a lot of cases. But atrial fibrillation is it's a abnormal heart rhythm where the sinus node is no longer functioning. So you kind of have a main generator that sends electrical impulses through the upper chambers of the heart and then down to the bottom chambers of the heart in order to cause contractions. I mean, his example, it's a V6 engine. Well,
right.
The V6 engine doesn't run without a battery. So the sinus node is our main battery. And when that goes out, atrial fibrillation can occur, for instance, and that is where there's chaotic impulses that are being created from the upper chambers of the heart, and it can cause the heart rate to go very fast, and it can make people feel their heart is skipping or racing.
Right.
But the other big danger about atrial fibrillation is not does it just make people feel poorly, reduced exercise tolerance or the palpitations or shortness of breath, but it's one of the leading causes of stroke in this country. I mean, we see a lot of people that come in with stroke and we check everything, check their brain, check their neck arteries, we check their heart, And sometimes they leave the hospital without a clear reason. And so what we end up doing is putting a monitor on the patient because we know that if you're in that age group of 60, 70, 80 years old, atrial fibrillation may have been the culprit, and we just didn't see it when the patient came in.
Right.
So we can implant a little recorder underneath the skin, which is a very quick procedure, which will allow us to monitor the patient for 3 years to determine if they had that atrial fibrillation that caused their stroke.
So since you took that, I'm not interrupting you. I want you to explain that a little bit more. So that is implanted underneath the skin near the heart.
Correct.
Is that correct?
This is called an internal loop recorder.
Okay.
And
an internal loop recorder.
Internal loop recorder.
Okay.
We make a small incision, no bigger than the size of my pinky fingernail, and right along the sternal border here, numb up the skin, make the little incision, and the device goes underneath the skin. We use a little glue or a stitch, and we close you up. And really, the procedure is about a 3 to 5 minute procedure at most.
So what does this do once it's in your body? Is it, and I feel like Bluetooth, right? Everybody understands Bluetooth.
It's totally Bluetooth.
Okay, so explain that to people who may not know what Bluetooth technology is when you have something implanted in you near your heart. Because it's a little freaky if you don't know about it. You
right.
know?
I mean, it's no different than now when you get in your car and you got your cell phone and it automatically connects to your car, right? So you can connect these devices to your cell phone and it uploads the saved data from monitoring your heart to your cell phone, or there's a monitor next to your bed, and every time that you come sit in bed and you're within this little monitor, it receives the information just like you got in your car and you connected to your car. And then it uploads the data to the cloud, and we can review the data off of the cloud and say, you know, especially if someone had symptoms, you know, Dr. Ossie, my heart was racing today. Well, we can go in and look once you've done the download and see, wow, they were in AFib today. And this explains why the patient had a stroke 3 months ago. And why is that important? Because now it changes our management. The patient may have gone out on maybe aspirin or a cousin to aspirin called Plavix. But now, if we document that the patient had atrial fibrillation, it allows us to place the patient on the proper medication, such as Eliquis, Xarelto, or Coumadin. And there's many patients that are still on Coumadin because of this whole thing of non-valvular atrial fibrillation. So it's really, in a nutshell, if you've had a valve replacement with a mechanical valve, those are the patients that really need to remain on Coumadin.
I see.
And cannot take one of the other drugs. Also, there's a condition called mitral stenosis, which is where one of the doors does not open properly.
Right.
And those patients should remain on Coumadin. Other than that, for the most part, these newer medications are a bit safer than Coumadin and are easier on the patient. There's less drug interactions, less food interactions. So they don't have to worry about getting their self checked with Coumadin all the time. Because when you're on it, you got to get finger sticks or you got to go to the lab and get your blood drawn.
So Dr. Mulukatla, I'm sorry, but you know what you get? You get the questions about drugs. And we joked a little bit about this too before the show started. So Dr. Ossie said, just throw those all to you. So I would like for you to describe what Coumadin does. If I remember, it's just a blood thinner, right, at the end of the day. But then there's all kinds of controversial questions about statins when it comes to heart. So I would love for you to, and again, you don't jump in, maybe you can jump in, but feel free to have a conversation with yourself. But let's start that conversation of what different medications physiologically do in the body. So we can start with Coumadin, which is, the way I think of it, as a blood thinner. If I'm wrong, please tell me. But then let's talk about cholesterol, high blood pressure, low blood pressure, LDL, HDL, when statins come in, because I feel like that's always the question everybody wants me to ask. Like they know we're doing a cardiology show. You need to ask about statins because I'm not sure. So that's my job tonight, from the people that know that I'm doing a cardiology show tonight. So take that any way that you'd like, and we'll have Dr. Ossie and you kind of bounce back and forth. We won't spend too much time on it, but it's a curiosity that everybody has.
Yeah, we can take statins. To be honest, the cardiology field in the last several years has changed that we have umpteen new medicines. We are talking about statins, but there's even new medicines that can drop your cholesterol that are injectables that people can take. And I have people with cholesterol levels of like 10 or 11. And I'm
Cholesterol levels of 10
yeah, like
or
their
11.
LDL is 11 or 12. I just saw a guy say, you win, a couple of weeks ago. So he's had such bad disease, and the statins weren't good enough that he had to be on other medicines. So we can start with statins. Statins are medications that work to decrease your bad cholesterol. When you go and get your lab checked, you get your cholesterol, you get your bad cholesterol, your good cholesterol, your triglycerides, and everyone kind of compares them and says, mine's good, yours bad,
Right,
or
exactly.
what's going on. And unfortunately, genetics play a role, lifestyle plays a role, how healthy you are plays a role. And you can really make a difference with lifestyle changes and being active and eating well and eating healthy. But statins themselves are very beneficial, and they're recommended in certain instances where people have had a heart attack or have had bypass surgery, or they have blockages that might be significant, or their cholesterol level is at a certain level. And the American College of Cardiology even changed some of those guidelines in the last several years, where we have a calculator, and you can do this at home, and you can plug in your numbers and see where you work and where is your 10-year risk. So you get to determine whether or not you should or should not be on that medication. Now, there's controversy with any sort of calculator, but this is one specific thing that we have. And so there's been discussion about what's good, because we used to treat to numbers. An LDL, which is your bad cholesterol, less than 70 was the goal, and then some of
Right.
these changed. And then we said, well, we shouldn't necessarily treat a number, but we should have people on the medications. And then in the last few years, and I'd let Dr. Ossie answer as well, but we have something known as a Pcsk9 inhibitors, and I don't want to go through all the different physiology, how they work, but these are novel medications where if someone's cholesterol is not well controlled, or they have really high levels, or they've had bad disease even being on statins, we can also give them injectable medications. Now, what is interesting is, because people do like to talk about statins a lot, and I love patients, but when you start a medicine anytime, oh, today this medicine started and I think this might have caused my problem. And it quite may be the problem. But it also is, when we're taking something, we're always worried about what we're putting in our body. And so what is interesting in the last several months, and over the last year, they've done several studies where they gave people statins and they gave people placebos, and they said statins cause a muscle aches or myalgias, people have found, and so sometimes people get concerned about that. Well, when they did this study, what they found out is both groups, whether they had the placebo
Right.
or the real one, they both equally had it.
It's a psychosomatic
So
thing.
there is some benefit to being on a medicine, and unfortunately there are changes that occur, and they can be helpful, but there are concerns with medicines, and I'll let Dr. Ossie continue with that discussion.
Well, I think one thing that I think is important for the public to know is that these statins have been around forever.
Right.
I mean, when I was in medical school, statins, there was enough research out there to show how beneficial they were. And I want to make sure that it's clear that if you have had a heart attack, or you've had stents put in, or you've had bypass surgery, the research clearly shows that you benefit from being on statin, from prevention of future heart attack.
So what does a statin do physiologically with your body? Is it opening up ways? What is it doing inside your body physiologically?
So that's a great question. So we know that the statins affect, like, everyone wants to look at the number, right?
Right.
Because we
Right.
know that the statin is going in the body and lowering your bad cholesterol, the LDL. But really, the crux of the issue a couple of years ago, where the guidelines changed and we're saying, well, don't focus on a number. Don't even use the LDL of 70, because it really doesn't matter. What really matters is that you're taking a high level of the statin. And the reason for that, and the reason that we believe that statins are so beneficial at reducing future heart attacks and death, is because it's really an anti-inflammatory agent that reduces the inflammation in a cholesterol plaque or grunge in your artery, that prevents it from rupturing and tearing.
Okay.
And that is really why we believe that all patients that come in with heart attacks, that have had heart disease documented that really you should be on a statin and you should be on a high-dose statin. And yes, we have all kinds of great technology now to replace statin therapy for people that can't take it, such as people that develop the muscle problems or liver issues, which can occur with statins. But I mean, it's a low incidence of those occurrences. And you know, we have seen the research from all these years, and it just always is overwhelming. I think the biggest controversy that always comes up with statin therapy, and he hits on it on the Dr. Mulukutla about, you know, muscle aches and stuff, but there's also all kinds of stuff in there about, is it going to cause me to have dementia? Is it going to affect my diabetes? And really the research, I mean, if that was really the case, all these drugs would be pulled off the market.
Agreed. Right. And I love that you're speaking so specifically about it, because there is all this fear out there. And what we try to do with this program specifically, 25 years, is trying to figure out what the myths are and what the true issues and situations are. So thank you for that. I'm not going to spend too much time on that. But what I do, Dr. Mulukutla, you talked earlier about the heart and you talked about the brain. And so I have a question here that's talked about the heart and the brain are so linked in terms of the human body. What does this mean to El Paso? So when you're talking about electricity, I think about it electricity, but you said the brain is also a big part of it. What did you mean by that? And maybe explain a little bit more in those ways.
Yeah, so the brain is important simply because it performs a lot of the actions that we want to do throughout the day.
Right.
But the brain and the heart are linked in many ways. There's the vagus nerve, there's neural stimulation, like when someone passes out or has low blood pressure or has a fight or flight response because there's someone coming that's scary. These are interactions that the brain tells the heart what to do, or vice versa. And as a result of that, your heart rate might increase, your blood pressure increases, and you become where you're increasing your contractility of the heart. Similarly, when you sleep, you don't need to necessarily do all these different interactions or different things, so your heart rate goes down and your need for certain things and your overall metabolic activity goes down. So there's a link, and there's a lot we understand and a lot we don't understand, but we have terms like neurocardiogenic syncope, where people pass out and we say, is it the heart or the brain? And it sort of goes together, and sometimes it's a combination of these factors. But the important part is the vascular structure from the heart feeds the brain.
Right.
So if you have disease in the arteries of your neck or your head and neck or your valves or your arteries, they can be the same disease patterns that are occurring in your brain. So there's a disease process that's linked, but at the same point, they're obviously very different, but they do have interactions like everything else in the human body.
So here's going to be my portion of trying to be preventative in the world of where you're going to stop stressing out because you're going to have a heart attack. You know, you hear a lot of these things. So when we're talking about the brain, you're talking about stress, you're talking about how you interpret things. This might be the way to plug exercise, meditation, yoga, whatever it is, because that doesn't only have an effect on your body. It also has an effect on your brain and how that relationship is. If you can spend a couple of minutes on that, I feel like I need to do that in every program so people understand that there is really a correlation there.
Yeah, and I think stress is a big part of heart disease and what we're having happen to the heart itself. People can have a heart attack just simply because of stress or the buildup of that. That can raise your blood pressure. You know, really being healthy and taking time to make sure that you are doing exercise, whether that's meditation or other things, to help de-stress or try to decrease some of that within your life is important, because we're constantly in a rat race every day of the week, and you know, taking time for yourself and making sure that you concentrate on those things that are both important from an exercise standpoint, but from your mental health, are really important. And we know today too, mental health with the pandemic has become much more difficult, and the services are also difficult, and there's a lot of people struggling with it. They have consequences which we will see and which we don't understand in some cases as well.
Right.
So I think they're all important.
Yeah, and I'll say, you know, just a comment on that too, you know, over the last couple of years with COVID, you know, El Paso and really the nation has seen the emergency room visits decline by over 30%.
Right.
It sounds like it's a good thing, but it's really not. And so what we found and what we've seen in our own hospitals is that now these patients that thought it was chest pain thought, oh, it's okay, it's heartburn, I don't want to go in because I'm scared of COVID, I won't go to the hospital. And 4, 5, 6 months later, their disease stage has progressed to even worse.
Right.
And so, kind of piggyback on your question of the preventative, it's if you feel that pain,
Don't not go to the hospital.
Don't wait, right?
Right.
See your primary care, see your cardiologist, or come to the emergency room. It's better to be safe than wait till later on.
So that's a perfect time, yes.
So I was going to just point out one thing, but so when we looked at data in 2018, 19, when the pandemic, pre-pandemic, heart attacks were at this level. During the pandemic, if you went to New York City, and they did studies in Italy too, the number of heart attacks dropped off dramatically.
Interesting.
And what's interesting today is it still hasn't come back. If you look at the number of myocardial infarctions that we had at that time compared to what we had several years ago, and it's not that people aren't having heart attacks, it's that people unfortunately probably dying at home.
Exactly. It's
And
not
so that's an
reported.
important point, just to piggyback up on what,
exactly right.
what
And
Rob's talking
you
about.
hit the nail on the head. It's not that they're not there, is that people are not going to the hospital. And Rob, I'd like to expand on that. I know that people think that we're out of it, we're not out of it, this and that and the other. Talk to the audience about what you all, hospitals, different medical facilities have put into place so that if you have COVID, that's a whole separate thing. If you still have all the underlying conditions you had prior to COVID, they still need to be taken care of. And this is how we're going to get you into the hospital. This is how we're going to get you to see Dr. Ossie. This is how we're going to get you to do what you need to do. Explain to the audience at home that procedure of being able to go. If they really think they have a problem, do they still call about ambulance? Do they still go to the hospital? Should they be scared? I know you've got this like down to a science, this speech.
And the unfortunate part is we've been dealing with this for over 2 years. So I can't say we're good at it, but we're pretty good at this. And this is all hospital systems. And so, as we look at that, I encourage people to go see your primary care doctor, come to the emergency room, because it is safe. Calling 911 to get the ambulance is safe.
It's more safe there than it is anywhere
It
else
is.
because the procedures in place.
They sanitize, they clean, and it's just going to be, how we have the flu. The way COVID is now, we're going to take care of patients just as we have the flu, right? So we still continue to wear masks. We will wear masks in the healthcare settings for quite some time. The state may change that regulation. The CDC is going to change some guidelines. But in healthcare situations, we're going to be there. Of
course,
right?
right.
And so we have all precautions in place where we're screening, we're having the PPE. There's not a shortage of PPE. Our staff, our physicians are aware of the safety precautions, and so for a patient to come in, they should feel safe.
Right.
They should feel comfortable coming in. They should feel comfortable calling 911 because it's needed. It's the right thing to do to ensure they're getting the right care.
Exactly. And we don't want people, again, suffering needlessly or having, as you said, either dying at home or really complicating their issues because they're scared to go to the doctor or to the emergency room. Dr. Ossie, just because it's your turn and you haven't talked in a while, I want to talk about, we have about 15-ish minutes. If there's something we haven't talked about yet, but I do want to talk about intervention with cardio. I want to talk about stents. I want to talk about if you see something going on in an individual and you, both of you, know how to prevent it or prevent something big happening in the future. What are some of the most common things that you can do as an interventional cardiologist that help people 10, 20, 30 years down the line? And Dr. Mulukata, I would love for you to maybe piggyback on that and kind of join in that question. Because I think that's a big thing. Prevention, if you can, you kind of know some of the markers. And what is it that you do pretty often to help people out?
Well, again, as I was talking earlier about primary and secondary prevention, primary prevention is the term that we use to identify a patient that might be at risk for having a heart attack or having clogged heart arteries. Secondary prevention is kind of why Dr. Mulukula and I are interventional cardiologists, because those are the patients that have had an event. They have come into the hospital and they're now having a heart attack, or they're having chest discomfort at home, pressure, tightness that occurs every time that they exert themselves. Shortness of breath, exertional fatigue are all very common signs and symptoms of a possible heart problem and possible clogged arteries. So what we can do is, if we can identify that the heart does have one of these gas lines that is clogged, we can go in there through an angiogram. Usually we go most of the time through the radial artery or through the wrist, sometimes through the groin, to go in, use a special catheter and place a balloon and a stent to open up the artery. And a stent is just basically a coil, stainless steel coil that expands and opens up the pathway to allow that fuel to get to the V6 engine.
Exactly.
As Dr. Mulakula stated earlier. So, I mean, that is one aspect of interventional cardiology that we both do. Other facets of what we do are we taking care of things like bad doors in the heart. I mean, that's getting into the realm of structural heart disease, and structural heart disease has multiple areas. I mean, structural heart disease can be related to thickening of heart muscle. It could be related to a hole in the heart.
That's a question actually from the audience. What does it mean when you have a hole in your heart? Right there. Yeah.
So a typical hole in the heart, the most common is in the upper chambers of the heart that we see, called an atrial septal defect or even a PFO. So it usually is a communication from the two upper chambers, from the right room and the left room, the right atrium and the left atrium.
Okay.
And that hole can, in certain patients, create major problems with high blood pressure in the lungs, or it could potentially create a setting for a stroke. Because if there's clot on the right side and it crosses from the right to the left, and the left has a direct communication with the brain, there can be a stroke in that setting.
Right.
And there are ways of closing that hole.
Okay.
It can be done surgically or non-surgically.
Okay.
So
It could be done non-surgically.
it can be done non-surgically.
Okay, sorry, that caught my attention. How do you close a hole in your heart non-surgically?
There's a button device, and Dr. Mulakula does these more than I do, so
That's perfect. Now it's your turn.
I'll let him. I'll pass the buck to you to talk about closing the hole.
Yeah, in fact, funny enough, this morning we had a patient come in. She's maybe 45,
Wow.
young lady, and you know, she's got a hole in her heart, which is that top chamber. We call it an atrial septal defect. And the way I describe it is basically, if you have a wall, you can have a hole anywhere in the wall.
Right.
And the most common hole in the wall is in the middle, and that's called a secundum atrial septal defect.
Okay.
And the way I describe it to patients is, everyone likes peanut butter and jelly sandwich, or at least somebody likes peanut butter, maybe you like jelly. But the way you close it is you make a poke mark in the groin. Now, again, understand that the traditional way of closing this has been surgical, but there are structural heart disease, or this discussion that we've kind of embarked on, is where you can do things without opening the heart. And these are the things that, you know, the Hospitals of Providence Sierra campus, the Heart and Brain Center, is going to be specializing in, and that's what they're going to be bringing to the El Paso market, and has been, and that's what they're going to be the leaders in, because they have been doing it, and they're the only place doing it in all of West Texas, as Rob had talked about earlier. But in this point, anyways, when you go across the heart, basically you take a piece of bread, and you have the hole here, and then you put it, and then you sandwich it with another piece of bread, and then that's this device, which is a occluder, and basically has fabric, and over time, once you allow that to close, the body absorbs it or grows over it.
So how do you get to the heart? Because I'm looking at this lovely device here that I don't know if people can see.
Well, this device here
That's completely different, I know.
This device basically is what we use to fix one of the doors that doesn't open.
Right. Okay.
But just
But just the idea of how to get there.
Yeah, well, and that is typically done through the right side and going through the vein. Basically, the vein connects to the right side of the heart and can easily get to that hole.
Okay.
And just so that everyone knows that's out there and goes, oh my goodness, I have a hole in my heart, I can get it closed. Not all holes in the heart can be
They're
closed.
not all the same.
Not all holes are created equal.
They're not all
holes are created equul.
And they can't all be closed through
Right.
that. The one that can be closed is the one that the secundum or the PFO type of hole. But this device is used to basically allow us to fix, you know, I'm going to commit. So earlier you asked Dr. Mulukutla about the mitral valve, the aortic valve, which is the most important.
Yes.
Well,
Sorry.
I'm committing the aortic valve. And
I get it.
I was going to tell him, be careful how you answer that question, because I know you like both a lot. But the reason I say they're both important. I mean,
Right.
in adulthood,
Right.
it really, when you're getting into your 60s, 70s, 80s, the aortic and the mitral valve are the important valves. When you're in your
Okay.
childhood, the pulmonic valve plays a pretty good role. But
Mm-hmm.
as you become an adult, the aortic and the mitral valve are your more common valves that are affected with age.
Okay.
And there can be some congenital problems that predispose you, things that you're born with, that predispose you to developing a valve problem in like the aortic position at a young age, such as a bicuspid valve. Usually the aortic valve is tri-leaflet, meaning it has three, I don't know if we can, you can basically see this, where you see that this is a tri-leaflet valve. And that is the way the aortic valve is supposed to look. But it can be bicuspid and predispose you to developing a heart-related problem at a young age in your 40s and 50s. And typically that type of problem where the door is bicuspid and begins to leak or not open properly,
Right.
that's typically going to be fixed surgically, because the patient is such a young age. We want them to get the most life out of just getting one procedure done.
Right.
When you get in your 60s, 70s, 80s, then the door has opened up to potentially fixing one of your valves, the aortic valve especially, through a means of placing a stented valve through the groin. So both of these are two types of valves that can be used to fix the door that can't be open. And we get to the heart that way by going through the artery in the leg, the femoral artery, and it's a direct conduit to the main pipe, the aorta. And we can then place this valve using this long device from outside the body and insert these new valves without going through
the heart.
open heart surgery. And that's called the TAVR or the TAVI, transcutaneous aortic valve implant.
And how things have changed over the last 10 years.
The technology is unbelievable.
I can't even imagine. So every time we do a cardiology show, I feel like it's completely different than the year before. Completely different than the year before. I'm getting calls from the audience right and left. You know what? I'm going to let that one go for just a second. Dr. Mulukutla, I was thinking about a question I was going to ask you as Dr. Oski was talking. I want to talk, so I don't want to make this into a pediatric heart show in any way, shape, or form, but I want to know, since you deal a little bit with pediatrics and cardiology, what is the most common issue that you see with cardiology and pediatrics? Because we talk about, you know, once you're 50, 60, 70 years old. Usually it's a congenital thing, I'm not sure, but what do you see when there is something happening in a child's heart most commonly?
So briefly, congenital heart disease is a fixed number. It occurs in 1 in 100 births or 8 in 1,000.
Okay.
So if you go across El Paso or anywhere in the country, 1 in 100 might be born with a hole in their heart or have a problem. They can even be born with 3 chambers instead of 4 chambers. There's a wide variety. But typical problems that kids have as they get older is someone hears a noise in their heart, a murmur, which might mean that there's a valve problem at a young age, or it might mean nothing, because 50% of kids have a murmur when they are born and they get to the age of 18. And those are innocent murmurs, or things that are not very serious. Blood pressure, as we have, unfortunately, people are more out of shape, and we do have that occurring, that we have people that are younger age having blood pressure or cholesterol problems. And so, unfortunately, certain disease processes that were often thought to be the adult that are now occurring in younger kids as well.
Right.
But these are the major things that we see. Either you're born with a problem that's very serious, or you have ailments that need to be dealt with that might be things that start in your teenage years.
And so it's funny, the camera was not on us, but when you said murmurs or click or whatever, both Rob and I were like, hey, that's us. So it is a pretty large percentage of the population. I do have regurgitation of a mitral valve. Sometimes you can hear the click, sometimes you can't. I go every 4 or 5 years. I wear my little device. What's your normal AFib? You know, you're going to be fine. It's chronic but benign. And I think there's so many people that are like that. But I love to, because we don't have that much time though, with people that have murmurs. And murmur is such a loaded word, right? Dr. Ossie, you're looking at me. So when somebody says, oh, you have a heart murmur, what does that mean? I mean, it could mean a million different things, but I'll let you take that.
It can, but I mean, basically a murmur is just a sound that we hear. I tell patients it's turbulence of blood flow. So take your garden hose and kink it when it's on. What does it do?
Murmurs.
Yeah. I mean, that's turbulence of blood flow.
Right.
And whether the turbulence of blood flow is from a door that doesn't open or doesn't close, it's going to create a murmur.
Right.
And that's most commonly, I mean, there are other things that can cause a murmur, but for the most part, we're talking heart valve disorders, and it's one that either doesn't open and doesn't close, and it creates turbulence of blood flow. No different than when you kinked your garden hose and you hear that funny noise.
Right. So sometimes it's not something to freak out about, but it is something to keep your eye on, which is what Rob said earlier. If you kind of know there's stuff going on with you, whether it's COVID or not, make sure you get things checked. And Rob, before we wrap up, I wanted to ask this, and you may have touched base on it earlier too, but it was about just some advancements in care at the Hospitals of Providence over the last several years. And I know we're here for cardiology, but just in general, and I know all hospital systems do this, it depends on, you know, it all depends on funding, right? And that's the terrible, ugly, icky thing when you talk about money. But when you're looking at these devices, they cost money. But at the same time, without these devices, advances can't be made. On that note, what are some of the advances in cardiology, and you're welcome to throw these two guys' way, in the last, and we just talked about it, you know, like 2 or 3 years, things changed drastically. What are some of those things now that you guys have in place that you didn't have 5 years ago?
Yeah, and I think, you know, it's going to continue to change, right? I think each 1, 2, 3 years, the advancements are going to continue to change, and we, as a hospital system, as physicians, have to adapt. One of the things that we did, you know, yesterday, which has been about a 10-year journey and multi-million dollars, is dedicate ourselves to be a heart and brain center. Hospitals of Providence Heart and Brain Center.
And I want to talk more about heart and brain. You've said that several times tonight.
Yeah, and it's just advancing the care for the heart and brain we talked about before. You know, probably the two of the most important pieces of your body under one center, right? And it's the advanced cardiologist, interventional cardiologist, you know, that we have here. It's a neurointerventional radiologist, and it's really it's taking that level of care and meeting the patient needs, and that comes with the advancements of technologies, 3D mapping that we have the capabilities of, you know, guided imaging for surgical equipment, you know, the hybrid OR that we use, that they use to do the TAVR. Just the advancements that do cost money, but it's the right thing to do for patient care.
Right, absolutely.
And so, you know, I'm excited to have both of these physicians here kind of part of that program, because it's providing great care to our home here in El Paso.
Absolutely. And we're getting to the point where we're slowing down, so not slowing down, speeding up, but go ahead.
I mean, he's being very modest. I mean, the Hospitals of Providence have totally stepped up. This is specialized care. They have gone above and beyond to say, we are going to focus this institution on dealing with heart and brain issues. I mean, that is huge. I mean, you're taking, I mean, if you go to Dallas, there's a heart hospital. You go to Albuquerque, there's a heart hospital.
Right.
They are taking that step to say, we are going to do everything and anything to make sure that we provide the best possible care to the patients that come in with a stroke or a heart attack. And that, you know, that comes with, if you're a patient, that's where you want to go. You want to go where they're doing the most volume. Where do all the heart surgeons do their open hearts? There's 4 Hospitals of Providence, and we are doing them at Sierra, the Heart and Brain Center. That's where you want to go get your surgery done. Where do you do the most? Who is there doing the most cases? That's where your physicians, your staff are all in tune to specialized care.
So it's practice, 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 just like with anything that we do.
Correct.
Dr. Mulu Kutla, is there anything that we have not talked about this evening that you'd like to talk about really quickly before we start wrapping up?
Yeah, our goal is to improve the care in the community and to be able to advance cardiovascular care. In 2018, you know, a lot of these procedures we talked about, we didn't do. Today, we will do over 300 of those types of procedures without opening someone's chest.
You
this
do
year.
over, I'm going to have you
The,
repeat that.
the
You're gonna-
hospitals of Providence,
Okay,
Sierra, the Heart and Brain Center, will do
Right.
over 300 this year.
without opening up.
Since over the last 3 years.
But that's huge. That's huge without opening up the heart. Because remember the days we were like, oh, you got to pop the chest cage open and the ribs are hanging out there and you got to do heart stuff. That's huge.
So there's so many different types of therapies we do. We can fix the aortic valve. Tomorrow we're going to fix mitral valve prolapse in a couple of people by putting an extra hinge on a door, 3 patients. We're going to be doing a tricuspid valve repair in a few weeks that's never been done before. We've fixed the pulmonic valve 10 or 15 times. There's a lot of therapies that we can do, but there's a lot more that we want to do and be able to continue to do. And what Dr. Ossie is saying is important. We couldn't do these things without the support from Rob, from all the other physicians, from our staff. You know, we're really being able to put forward what's best for the community and really change their ability to get the best care, not that the care that they need, but the care that they desire, and they can stay at home with their families and get good quality cardiac care.
Here at home in El Paso.
Correct.
Robin, we have you wrap it up in just the idea of saying thank you to all your staff. That's what you have to do right now.
Yeah, absolutely. And I try to thank them every day, right? And I think it's been a challenge for all healthcare workers over the last couple of years. And thank you for to everybody for doing that. But we talked about it yesterday in our unveiling. Is without the staff, without the physicians, our hospital wouldn't be there.
Right.
And so I'm just excited to be part of this journey, be part of the advancements, and I think there's more to come.
And I have to say, I'm so proud of El Paso, too. You hear about it in not just national news, but international news, and how well we've done with COVID and dissemination of the vaccinations. I know this is not that show, but you guys were a huge part of that. All the hospital systems in El Paso really gathered together and did that. So on that note, too, if there is a heart issue or any other kind of medical issue that you have, do not delay your care. The hospitals are ready for you to come in. The COVID practices are all in place for you to come in, so do not delay the care. If there's anything that we can say during this time frame, that's so important. I want to say thank you very much to Rob Anderson, again, CEO Hospitals of Providence, Sierra Campus. I want to say thank you for Dr. Mulu Kutla, and then also Edward Assi, who all are both Aussie, our cardiologist. I'm Catherine Berg. Again, this is our 25th year of doing this program, and I'm just being counted down now, so I'm waiting for the 6 whole seconds where I can say thank you. This has been the El Paso Physician with the El Paso County Medical Society. Good night.